Good morning. I would like to welcome you to the GST track. My presentation is about how we select and prepare patients for the group schema therapy. My name is Magdalena Kitlowska. I'm a psychotherapist from Poland, from Warsaw. I'm a trainer supervisor in both individual and group schema therapy. I'm also a CBT therapist and executive board member since 2022. I hope you will enjoy. So let's start. As you are probably aware, there are different group therapy formats depending on modality, on the setting of the group therapy, like is it inpatient clinic or a private practice. So we can think about groups as being heterogeneous. So we deal with different personality types or different problem constellations. Or they can be very homogeneous, which is dealing with specific issue, specific condition, for example, social phobia or rape survivor groups. And of course, depending on the type, we will have an impact on cohesiveness. So the homogeneous group will be very cohesive from the start. And they will cooperate well in the beginning, but also we will have a limited range of vicarious learning because the repertoire of modes and experiences will be much wider in heterogeneous groups. Again, another question is it an open or closed group? So open group is when every now and then new members are joining the group, or the group starts and finishes with very much the same number of patients. And of course, this decision or this format will impact, again, a group process that needs adaptation to a so-called rotating theme groups. For example, on inpatient units, when a typical time for staying off the patient is about 6 to 12 weeks, and every few weeks new patients join, older veteran patients leave. So the theme of the group needs to repeat if it's program-based group, and of course the dropouts. Another question quite closely related with the group being open or closed is it time limited or is it open-ended and the patients just join and leave after a certain amount of time? Another dimension of group therapy is it structured based on a program, on a skilled building training, or is it more process and emotional exploration, or like existential groups? What happens here and now is what is leading the group. And usually most groups are facilitated by a pair of co-therapists. In CBT groups, one therapist can serve as the main therapist. Now, when we think about group schema therapy, the typical format is that groups are usually heterogeneous. So we collect or create a group that is consisted of participants with a mix of schemas and mix of coping modes. So usually different problem presentations, unless it's a program dedicated to a very specific population, and for example it's a research on therapy, like borderline patients or antisocial personality disorder within the forensic setting. Usually they are closed, so when we start the group we don't include new patients. We tend to run the group with the same group of patients until the end. And usually they are time limited, between 20 to 40 sessions in the program. We prefer to conduct the therapy by two co-therapists who flexibly change roles between themselves. And of course, it's best if they're both present from the very, very beginning. So from the moment of selecting the patients, the interviewing the patient to the group. It's important that there is always an element of psychoeducation. So in the beginning of a group process or the group program, because some patients, of course, will have some experience with schema therapy, but some might be quite new to it. And we want the patients to have an equal or similar knowledge of the basic vocabulary we would be using, like what are the emotional needs, what are the modes, what are the parent modes. So it's important that this psychoeducation, so that the theory, shall we say, is very much combined with experiential work. So this is main part of the group schema therapy. So there is also a balance in every session between experiencing and reflecting on that experience. So again, to increase the learning and the change. And typical frequency is once a week between 90 to 120 minutes, depending on the size of the group. And of course, before we start recruiting to a new group, we need to answer a few questions. We as the therapists running the group. What's the duration and frequency of the planned group? And what is realistic? Because we need to as well assume that people on, during holidays will just not be there. So it's best to plan each session week by week and present that to our clients, our patients, before we start the group. It's very important to have a co-therapist and agree on who we are including or excluding from the group. And if there is an agreement about it. Is there a specific focus that the group would be about, like shame or avoidance or intimacy problems, whatever you want to focus on? It's very important that you and your co-therapist can schedule interviews together to have shared view and reflections on each patient. What's the minimum and maximum number of participants? Usually in group schema therapy, we wouldn't go below 6 patients in the group, and maximum is usually 12. So usually the safe number is around 10. And it's important to make a decision if anything needs to be changed or added to the typical ground rules before you start the interviewing process, because during interview we're also covering typical ground rules. So for example, if you're handling the group schema therapy online, you might want to add some rules regarding not using other programs or just having your door closed or having earphones, but basically staying focused and undistracted during the online session. So you might want to include those additional ground rules that are important to you into a typical set of rules. Selection of participants and basic preparation, so the first phase before the group therapy starts, has two major areas. One, of course, is assessment. That will be quite similar to individual schema therapy, where we would be examining life themes, therapeutic alliance, and dropout risk. And of course, a pre-treatment preparation, when we would be covering ground rules and potentially recordings, also talking about some worries or expectations. And we could recommend some basic psychoeducation, like reading or some articles that would be available for every patient. So before I will move to covering selection or preparation in more details, I think what is really important is this process of selecting and preparing patients to the group can take up to a few months, sometimes 3-4 months. and it can be few meetings with co-therapists, where we would be, of course, collecting information. We would be checking the responsiveness to both therapists. What are the expectations, worries? What's the collaboration on rules and goals? What is the risk assessment? So during all this, also the co-therapists are creating their bond, their relationship, checking how they exchange roles, how they respond to each patient. Is there any issue arising in co-therapy? So this process is, on one hand, preparing the patient or assessing the patient, his suitability in this current moment, his readiness for the group therapy, but also forwarding and checking with your co-therapist, is everything going okay? Should there be some changes? Should they develop some better cooperation? So this is a parallel process that happens to the therapists during that process as well, and work on any issues with their supervisor if anything arises. So let's move to basic schema therapy assessment. It's very similar to assessment in individual schema therapy, although it's usually more focused and more time limited, because we know that we would be meeting or offering the group for 20, 25, 30 meetings. So we also have to be quite realistic what we can achieve in that time. So of course the first major question is, what are the presenting problem? Why the patient is looking for group schema therapy? What are the live themes? And of course we are forming it in a schema language. So what are the unmet needs that fuel modes, coping modes? What's the history behind it? So what was the childhood and adolescence experience? What was the relationship with parents and peers? And what were the unmet needs? Especially this information about the quality of relationships is very important in group schema therapy, because here, unlike in individual schema therapy, we have more people, more interactions happening at the same time. So in individual schema therapy, it's much easier for the therapist to adapt and address any issue, any rupture in relationship with the therapist or between the therapist and the patient. In group schema therapy, it's much harder to monitor and adjust to everything that is happening, because there are much more complex relationship with other group participants. So we really need to see and understand how the patient might be reacting to his peers, for example, looking at his past experiences. Of course, we will identify central schemas and modes within the problem that patient wants to work on, and of course understanding the coping styles. What are the goals that the patient would like to achieve closer to the end of the group therapy? And again, here we need to be realistic. Often within 30 meetings, we are unable to achieve 100% of the goals, but maybe 80, 70%. And it's good to be realistic about it. It's about moving forward toward the goal sometimes. And of course, this is the major question. In group schema therapy, we focus on selected problem and selected goal. It's not like, unless it's an exploratory group, which is, let's just find out about our schemas, our modes in different areas of life. The typical group schema therapy is built around each individual problem of the participant. So it's both individual work, but also working with the group and the themes that arise within a group context. While doing assessment, we can use more experiential techniques as well. So for example, imagery in diagnosis. which allows us as therapists to check how easy the patient can access memories and emotions. We can do a typical safe place or safety bubble technique, or ask the patient to connect, starting from a current situation, asking him to close his eyes and bring back the memory when he or she felt similar emotions or physical sensations in the childhood, and getting this just this image without any rescripting. Yeah, so it's also early learning for the patient what to expect during a group therapy. What are the experiential techniques about? And of course, it's important that the patient has liberty on how descriptive he wants to be. Yeah, talking about his memory, and also, and it's important information, that within the group therapy we would not be scrutinizing the details of especially distressing memories. The patient still could choose how deep he want to go, or what memories he just doesn't want to talk about. So that limit or that safety rule is always there. Using this technique, we can identify what is triggering the schema, how the client is experiencing it, how we can notice how the client is behaving. We can understand the origins in the childhood of the current problems and schemas. And what is most important is this combination of active, so experiential and passive methods like interview, is found to be the most effective in understanding and preparing the patient for the group therapy. During selection, we can also ask patients to fill in schema therapy inventories, like basic schema questionnaires like YSQ or mode questionnaire, SMI. We can as well use or give a bit of psychoeducation using SMORES. So it's an observation scale, mode observation scale. But of course, we need to remember that those tests capture subjective impressions. So it can be prone to self-presentation or manipulating the image, shall we say, because some patients with, let's say, more narcissistic traits could portray themselves as healthier, more adjusted, and lower scores about aggression or impulsiveness. And of course, tests don't measure all aspects of schemas and modes, yeah? And they don't tell us how they were really developed. So this is something we need to understand using interview. But it's also good to have the spread of all the group, of all participants, to see how they fit in, how they could be interacting, but also that gives us an idea later on in the group when, let's say we do, for example, role playing, how to allocate roles, because for a patient who has pretty high compliant surrender mode, so is very submissive, very agreeable to other patients, and is not really telling how he feels. So that's the compliant surrender mode. Allocating a role of, for example, angry child, and asking him to express the anger might be very healing and very corrective. So we would have this information if we do the assessment early on, and we can think what would be the best role for this or that client to really help them out experiencing new things. Another element that we would be reviewing during the assessment phase is therapeutic collaboration. So thinking about the history of successful courses of therapy in the past of the patient. If the patient had a history of dropouts or changing therapist every now and then for various reasons, this would be, I don't want to say a red flag, but this would be something that should make us aware that the likelihood of a dropout is quite high. If a patient is in concurrent individual therapy and is joining the group to work on his social isolation schema, for example, that's also a positive sign. Being able to be in a therapeutic relationship is always increasing a likelihood to stay in a group therapy. And of course, if the quality of the past or current therapeutic alliance is positive, then it's a good positive predictor in all types of psychotherapist. And what is this positive therapeutic collaboration? It's if the client and therapist agree about the goals, ground rules, tasks of therapy, if there is a shared view on how therapy could work, how it could help, how the group could help. And of course, it's also important how not only bonding with therapist is positive, but also with other people. So if the patient has a history of positive relationships with other people, that's also a good predictor. And how do we assess the quality of the bond? So we would be looking for moments when the patient is accessing his vulnerable child mode. So when he's able to connect to vulnerable emotions, sadness, fear, or being moved or being empathic toward moments in his life, toward himself, toward other people, as he's telling his story. Another element that is important is that we are observing if the patient is equally responsive to both of the therapists, or he's rather just focusing on one therapist and avoiding the other, because these are things that will happen during the group therapy. If the patient finds it difficult to interact with more than one person at the time, or is just focused on one person, he or she might behave the same way during group toward the other participants. So avoiding interacting with some or just focusing on one person. That would be, again, something to observe and consider. The emotions of the therapists are also pretty important at that stage. Do both of the therapists feel ease to be empathic and supportive toward the patient, or is it that only one of the therapists is feeling ease, and what is being triggered in the other therapist? Why is the other therapist detaching, for example? So these are all, again, important information that could tell us what will happen during the group therapy. As we are reviewing or talking about the history and the problems of the patient and looking at the tests, we need to as well observe the coping modes. So if the person has moderate to high Boolean attack, also self-aggrandizer, so overcompensating modes, we would need to be careful. If this is a moment when the patient should join the group, or maybe the patient would need a course of individual therapy to lower or manage those modes before joining the group. However, if we have a group that has this type of issue, this type of problem, or this type of modes, and most of or all patients would be selected as having that mode, then it's quite okay. What we don't want is having aggressive patients with those that, for example, were victims of aggression or are scared of aggression. That wouldn't be a good match. And of course, another thing, if there is a history of positive relationships in the history of the client. It's always good to watch the balance between collaboration and autonomy. Yeah. So watching if the patient is just saying yes, no matter what he thinks or how he feels. So a pretty strong compliance surrender mode. And if the patient is open to share, accept a bit of reparenting that we would be doing during selection, and if he's agreeing to the rules and limits, because that's really an important element of group therapy too. Another very important part of selection is considering dropouts. Dropouts are basically very negative for the group schema therapy. It's lowering morale, it's lowering the optimism of the whole group. So covering that area when we are selecting the patient to the group is quite important. So if the patient is in acute crisis or is pregnant or is unable to attend regularly, we wouldn't include him or her into the group. As well as acute psychosis or patients who are actively suicidal. That's also a red flag. We don't want the group to be scared what's happening to this person if he or she didn't show up to the group. Predator or conning manipulation mode. That also would be a negative predictor unless these are forensic groups. And of course, intense abuse of drugs or alcohol or problems from the first axis. Then it's mostly CBT or addiction protocols. And if the patient has a history of dropouts from therapies, individual or group therapies, also would be a red flag to include in the group. And some general considerations about the dropouts in group schema therapy. As many research showed, group schema therapy has lower dropout rates than psychodynamic groups. Probably it's because, first of all, the selection is, as you can see, harsh maybe is not a good word, but it's precise. There is a lot of psychoeducation and building the insight, the intellectual understanding, what we are doing, why we are doing, how it's connected to the patient's lives. There is a lot of focus on safety, on rules, and on slowly developing the working relationship. So I guess that would be the major difference between those two approaches. Of course, dropouts are very disruptive for the group, as I said, so they are also more frequent if the group therapy is the first therapeutic intervention for the patient. We would still recommend to have a few months of individual meetings, individual therapy before joining the group, because it's a lot. Usually it's a lot for patients to stomach the group. And of course, difficult patients or more demanding patients would need more energy from the leaders, from the co-therapists. So there is usually less benefits for other members to include those very intense patients with, say, bully attack or self-aggrandizer modes. So we always have to think what are the benefits for the other members when we include a specific person. So the fact that somebody needs therapy doesn't mean he should join this specific group we are collecting, maybe some other group. Why it's also important to think whether we are including or not including a client. It's because if the behavior of the client, one client in the group, is very disruptive, then excluding this patient from the group, ongoing group, for example, for violating the ground rules, would also confirm his early maladaptive schemas like rejection, shame, defectiveness. We don't want that. It's better not to include the patient rather than repeat his experience from the past. And of course, we always need to think that maybe one patient might require a longer pre-treatment phase, so many more meetings, or having a concurrent individual therapy to really benefit from the group. Sometimes it's not yes or no, but what other conditions should be met so that the group therapy would be successful or beneficial. And of course, if we are doubtful, if we and our co-therapist are in doubt, better not to include this patient or meet him more times than other clients. So as we were collecting information, tests, doing some experiential technique like imagery or chair work, at the same time or closer to the end of the selection process, we would be also educating, preparing the patient. So these are benefits of spending maybe one session talking about schema therapy, talking about experiential techniques. So basically it's about having patient being less scared, less worried, by understanding the process or basically what to expect. The patient understands the objective, the roles, and what are the concept of modes. Also, it increases the optimism, and investing your time in preparing patients for the group will create a more cohesive group. So at this stage, and it can be a short workshop, playing a video and having a discussion with the patient, talking about the reading of the book or articles, but also adding some experiential work, as I said, will more likely produce a positive effect. So each patient will be more involved, more open to exercises we would be doing during the group therapy. But also, and that is quite important, especially for the overcompensating patients, that if we spend more time in guiding the patient before the group, they will be much more likely to follow our lead, obey the ground rules, accept the limits. So those leader-initiated tasks will be accepted much more. And of course, this is a moment to talk about the worries, expectations about joining the group. So for example, what scares me thinking about the group, but also, and it's really important, two questions: how the group can help me, and what am I giving or bringing to the group? So it's a two-way street, and building this focus on giving and taking. Yeah, this is what group is about. It's not me in the group, I'm not individual, but also it's about interactions. And of course, creating the group is the major task for co-therapists. So out of 15 patients, to select 10, 12 most suitable at this point is our goal. And of course, we need to remember that the group as a whole is much more than just individual patients being together. Yeah, they blend, they mix, they interact. So we need to think about as well helping that collaboration, that cohesiveness to happen. So we would be looking at common unmet needs or common coping modes. How many members are inhibited, or how much of a happy child we've got in the room. How strong is the punitive parent? How strong is the healthy adult? It's always good to include 2-3 patients with a stronger healthy adult or more advanced in therapy to boost the group. And all those common themes would be increasing the cohesiveness and safety of the group. Yeah, feeling close, feeling, oh, we've got similar problems, I'm not alone here. Yeah, we all have similar issues. And a short tip that I've learned years back from my psychodynamic colleagues. While selecting the patients, it's always good to remember about the Noah-Ark rule, which is when we are selecting patients, it's always good to have a pair, matching pair. So people who have somebody else in the group in a similar age or education level or gender or problems or race or modes. So we never have a singled out, isolated patient who cannot connect to somebody else. Of course, in the group at the end, members will connect, but it's much easier if, for example, you've got 2 patients on the autistic spectrum, not just one, or 2 men, not just one, yeah, because it does this rule prevents sense of isolation and also lowers the dropout rates or scapegoating when the patient is unable to fit in or finds it difficult to fit in. And as a bit of a final thought on this selection process is some patients might need also concurrent individual therapy. In group schema therapy, this is not a problem. I know some modalities are very much against it, like anything that happens has to be brought to the group and that's it. In individual and group schema therapy, it's not uncommon that we combine those 2 settings. Some protocols, some borderline personality protocols actually assume there should be individual meetings while also being part of a group program. So that's quite important that we've got a clarity. What are the reasons for individual or for group format at the time? So for example, a person might want to work on child sexual abuse, memories and issues in individual therapy and work on trust, building trust and connection in social context within the group therapy. That's absolutely fine. Of course, the question is, should the group therapist also be individual therapists? Because this is the matter of fairness of access to all group members. That needs to be discussed with your co-therapist. And of course, thinking that sometimes a patient might open up or remember in the course of group therapy some memories that he would like to or she would like to work on within individual therapy. That's fine. That's absolutely fine. Sometimes individual therapy helps to prevent dropouts from the group, so that will be very beneficial. Sometimes the content of the memories is just too disturbing for the group. Let's remember that often the group members have their own traumatic memories, and that hearing about equally upsetting events from somebody else's past might be just too difficult for them, too disturbing. And that's a really good place to bring to individual therapy room. And of course, the clear boundaries between both settings are important, because what we don't want is a group member coming and saying, oh, but my individual therapist said this and that you're wrong. We don't need that. Yeah, we need to have a clear boundaries within those 2 formats. But in general, it's beneficial, and we would absolutely allow that to happen during group schema therapy. So I hope that this short presentation gave you some ideas on how we are selecting patients and what is our focus before starting the group therapy. If you have any questions, please email me at this mail address. And I hope you enjoy the rest of the World Schema Therapy Day. Thank you.